All right, good morning to folks on Zoom as well. Alrighty, y'all. We are gonna do another Kahoot today. So go ahead and start joining. And while y'all are doing that, I am going to pull this out of the way and just make sure I've got everybody who's on Zoom checked in. So this is a Kahoot for the stuff we were covering last week. We just didn't quite get to it because there's so much material to talk about with disorders. So this is going to be about the personality disorders that we covered at the end of last Wednesday. Alrighty, I'll give it another minute or so for folks to get logged in, and then we'll go ahead and get started. That means most of the folks who are on Zoom. Yep, see a couple more joining. All right. Excellent, excellent. Folks rolling in. Great. All right, I'm going to go ahead and get started. If folks are still joining, I believe it will still show the game pin at the top or bottom of the slide. I feel like they're always moving stuff on me. Alrighty. So this one is called The Party. And it's like you're at a party and you're interacting with people, and which disorder do they have? Alrighty, so LaShonda danced in the party and immediately became the center of attention. With sweeping gestures of her arms and dramatic displays of emotion, she boasted about her career as an actress. She was asked about her troubled marriage, but denied any problems. Shortly after this conversation, she fainted and had to be taken home. Yeah, histrionic. There are some borderline traits in here as well, but the like wanting to be the center of the attention is a big part of the wow, I'm blanking. It's a big part of histrionic. Um, so go ahead and go to the next here. Early yet here. All right, so our next person. So Wilhelm wandered in the party, didn't stay long. Others said he was aloof and a space cadet. He said the room was filled with negative forces which were going to influence him in some way, and he didn't speak to very many other guests. Yeah, so this one, a lot of, again, schizoid, schizotypal overlap so much that in the proposed new personality disorders, they're just going to combine them, right? So totally get why folks would be like, I don't know which one it is. But technically this one's schizotypal, just because he's having sort of the weird experiences of thinking people are going to influence him. All right, seeing people move around here. Which PD does Winston have? So Winston is talking about his trip to Europe, his new Mercedes, his favorite French restaurants. People were bored around him, but he kept on talking about himself. He hurt a woman's feelings, but he couldn't apologize. He tried to talk his way around it and blamed her for being upset. Yep, a lot of people got this one right. Narcissistic, right? I think, like, in addition to just how we use the term narcissistic kind of like flippantly in our society, the idea of narcissists and especially narcissistic abusers, I think, has become more in the sort of fabric of things. I see a lot of like Instagram reels about it, so I'm guessing there's a lot on TikTok too. Alrighty, more people getting on the board. All right. All right, so Maria is laughing and giggling. She's flirting with the men. She's disappearing with different men. She had a violent argument with one of them. So she went to the bathroom and attempted to swallow a bottle of aspirin. Her friends encouraged her to go home, but she was afraid to be alone. Yeah, so this one's borderline, although it certainly has, again, histrionic flavors. Histrionic would be taken out of the DSM in the, again, sort of new way of doing personality disorders because it's so similar to borderline. But yeah, it's especially the suicide attempt gives it that borderline, I was gonna say flair, but that's not right. Feel, maybe. All right. And obviously this would have been a lot easier if we could have done it when we were going to do it, right after we talked about these disorders. It's almost been a week. So thanks for hanging in there. All right, so Jamal came at the party exactly on time. He spoke to each guest for 5 minutes. He talked about technology and finance and avoided any inquiries about his feelings. He left precisely at 10 p.m. because he had work to do at home. Yep. So this one's obsessive compulsive. Just that needing your day to be ordered and organized just so it's that type A personality, right? That's like, I got work to do, I gotta go. So yep. Good on y'all. Oops, some switch up at the top there. Like it. All right, so Donna. Donna watched the party from outside through the window. She seemed very uncomfortable. People tried to be nice. She looked guarded and distrustful. People became uncomfortable with her habit of finding fault in every little thing you did or said. She was picking fights and she didn't stay very long. Yeah, and this one, as I was rereading it, I was like, that could be avoidant. I think sort of the picking fights with people element gives you that paranoid. But as you can see, these disorders overlap so much, right? And that's why they want to clean them up for the next version of DSM-5. Righty, some movement, some movement. All right, so David wasn't invited. No one really knows him because he rarely talks. He's most comfortable when he keeps to himself. He spends most of his time at home alone reading, and that's where he was during the party. Yeah, so this one's schizoid, but again, I could definitely feel this as avoidant as well. Not quite antisocial because antisocial people can fake being charming. But again, the personality disorders are really overlapping, and that's part of the point of this activity. It's like I'm not expecting everyone to get them right because clinicians have a hard time getting it right. All right, so Tiffany arrived with one of her friends, would not leave her friend's side. She went to talk to a guy she liked, but Tiffany got really upset when her friend did this, and she didn't know what to do or how to act without her friend there. Yep, just about everybody got this one. This is dependent. This is that clingy koala that I had on the slides, right? Just like they don't feel confident at all if they don't have someone with them. All right, kind of holding firm here. All right, two more. And this is not Taj in our class. So intimidated by the party, he saw an attractive woman, but he was extremely nervous about talking to her. He feels inadequate, is fearful that people will reject and criticize him. So he left early without talking to many people. Yep, so this one's avoidant. Again, the big difference between this and like, let's say schizoid is that there's not that like someone's out to get me type thing. It's just they feel really uncomfortable around people and especially like getting close to people. Alrighty, oh, a little bit of flipping around there. Okay, so Max is our last person here. He talked to many people, trying to get them to buy into his new business venture, which was really a smuggling ring. His brother complained he was talking too loud. Max got physically aggressive with him, punching Mark. He showed no regret for what he'd done, claiming that Mark deserved it. Yep, so this one's antisocial, although again, certainly you could say borderline, right? It does have some of those features, and that's why those are both cluster B. But the like lack of remorse is a really big one for antisocial. And I like this example. I didn't write these are from an activity someone else came up with, but I really like this example because not everyone with antisocial PD is a serial killer, right? Some of them are just trying to swindle people out of money. And that's a good example of what Max was doing. Alrighty, let's see our podium here. And again, everyone gets full points just for participating. It's really about sort of sorting things, but I'm very impressed with the folks who are doing so well just because, again, we didn't cover this for like 7 days, so excellent job, y'all. Alrighty, so I'll go ahead and close that out. Yep. Alrighty. And let me go ahead and I think I need to stop share for just a sec. Yep, so I can hide the captions, reshare with the better captions. All right, so today, we just spent last week and the week before talking about the different disorders. And so today what we're going to start talking about is how do you help people who have these disorders? And we're going to talk not only about talk therapy, but about a whole host of different options that are available for folks who are struggling with these disorders. So what is therapy? It is an interpersonal relationship, not a romantic relationship, not a friendship relationship, but a relationship, a therapeutic relationship. It's got to be between at least two participants, and those are the therapist and the client. So the therapist is someone with special training and expertise in handling psychological problems. That person can be trained in a variety of different ways. I'm just gonna walk and talk and open the window. It's really warm. They turned on the heat and now it's like, we went from freezing to temperature boiling in here. So the therapist could be someone trained at the master's level. They could be someone with a PhD. More and more we're getting, folks who might be able to get some sort of certification even at the bachelor's level, although that's kind of rare and hard to get. But it's someone who has that specialized training and expertise. It's not some Joe Schmo off the street who's like, yeah, I'll tell you how to make yourself feel better, right? You want someone who knows what they're doing. And then you have the client, and that is someone who's experiencing some sort of psychological issue. And they've come to the therapist, they've entered into this therapeutic relationship in order to alleviate this problem, to feel better. Often it is a combination of emotional, behavioral, and interpersonal problems. So it's not just like feeling distress, right? It also might be that distress is causing you to act in certain ways, that's causing other people to interact with you in problematic ways. So this is an old study at this point, almost 30 years old? Yeah. But I think a lot of this would probably still hold up today. So this is a study where they looked at the use of outpatient mental health services. So these are, you're not going into the hospital, you're not staying there, you're just going for therapy, right? And so people are more likely to enter into therapy if they have insurance than if they don't, right? That makes sense. It can be expensive. The nice thing is that more people's insurances, if you do have insurance, cover mental health care now. That's one of the things the Affordable Care Act, or what's sometimes called Obamacare, did, is to make sure mental health was covered under insurances. In terms of marital status, that people are more likely to go to therapy if they're divorced or separated. Although again, we see married and single people as well. The more educated people are, the more likely they are to go. And my guess would just be these folks should probably just be more open to a lot of different things, might have taken a psych class and know what therapy is. I think there's a lot of misconceptions about what therapy is, right? You're gonna shrink my head, right? Or, oh, that's just such a waste of time. We see a lot in sort of this 35 to 49 age group, although I would guess with shifting demographics, you're probably starting to see people start to use therapy younger. Folks your generation and younger really do seem much more open to therapy than, say, even my generation. And more women than men are likely to go to psychotherapy, and I think that's probably largely due to judgment, right? Oh, you got to be a man, you got to be strong. Going to therapy is for the weak, when obviously it is not. One of my favorite things about the Olympics this year is how open many of the athletes were about going to therapy. So Simone Biles talked really openly about, like, I think it was the day she won her all-around gold. She was like, yeah, I had a therapy session this morning and I used all my techniques and it was really helpful. right? And she wasn't the only athlete to do that. So I think that that can be a really helpful way to sort of normalize it. So who is the person providing therapy? As I said, the therapist can have various different levels of training. So clinical psychologists are folks like me. They obtain a PhD or a PsyD in psychology, in particular clinical psychology. And then I did not go through this step, but people who want to do therapy then get licensed. And so for PhD PsyD folks, this involves taking a national level test. And then often your state also has a test where they basically make sure you know the laws of the state in order to be licensed there. Psychiatrists obtain a medical degree, an MD, and they're going to emphasize more the use of medications. Certainly, there are psychiatrists who do therapy, and actually some of the greatest therapies we have were developed by psychiatrists. But in just with today's insurance reimbursement system, they can often make as much or more doing a 15 to 20 minute med check as they can for an hour of therapy. So if you just math it out, right, it's if they do 2 or 3 of those and the time it would take them to do an hour of therapy, they can make a lot more money. And then there's lots of other folks who typically will get a master's degree and licensure at the master's level. And these include psychiatric social workers, psychiatric nurses, counselors, like the folks in our counseling center. I don't know what degree our new director of counseling services has, but I know that Brandon, our other full-time therapist, has a master's in social work. Various people who have worked there have had various different degrees. So you can get a master's in like counseling or clinical psych. You can get a master's that's specifically marriage and family therapy. And you would get all the training you need in your master's, you would get supervision and experience, and then again, you'd go through, usually at the master's, it's just a state licensure level test and going through all the red tape and paperwork. So lots of different people can provide therapy and can do it well. Social workers are going to differ from clinical psychologists because they have a lot more training and knowledge on how to connect people to resources. Counseling psychologists, counselors are going to also differ because they have a lot more training in sort of intersectional ways of looking at things and thinking more about the context of the client, although clinical psychologists are getting a lot better at this. The conference I was at this past weekend is a therapy conference, and maybe half or a third of the sessions I went to were about just that. Like, how do we make sure we're taking the client into account and not just like throwing a therapy at them? So we're going to talk about therapies from various different like theoretical approaches. And the first one we're going to talk about is biological. So in the biomedical approach, you want to reduce or eliminate symptoms of a psychological disorder by altering body function, just like you would try to reduce or eliminate the symptoms of a medical disorder, right? By altering body functioning. You have a thyroid issue, they give you medicine to treat that, and hopefully it resolves and your body functions in a better way because its function has been altered. Same thing with psychotropic medication and some of these other things we're going to talk about. So medicine or drug therapy is the primary thing we look at here, but there are a couple more extreme things that are done, including electroconvulsive therapy or ECT, and then also psychosurgery. One thing I always do sort of like a disclaimer about is that these two are never first line treatments. We always are going to try other stuff before we zap someone with electricity or like cut into their brain, right? So these will be things we do for folks who are resistant to like just drug therapy and psychotherapy are just not working for them. So there are medications to treat a whole host of different conditions, including anxiety and depression, the two most common experiences people have. So these medications affect the brain, and in particular, the neurotransmitters in the brain. So these all act on particular specific neurotransmitters within the brain that have shown to be related to the symptoms of these disorders. So for anti-anxiety meds, we have the anxiolytics. These are things like benzodiazepines, buspirone, Xanax, Valium. They are things that reduce tension and anxiety. The other really interesting thing is that some of the antidepressant drugs also work as anti-anxiety drugs. In particular, the SSRIs, which we're going to talk about in just a minute. The tricyclics are really the first antidepressants they developed in like the 40s, 50s, 60s. And these are still widely used. There are things like tofranil and Elavil. And these work specifically on norepinephrine in the brain, which is a neurotransmitter. And a lot of these are going to work by blocking reuptake of a medication. Now, what does that mean? Let me see if we actually have chalk in this box. We do, huzzah! So what that means is, if I can get the box open. Okay. Let's try the bottom. So what happens, and again, if you've taken 101 or maybe some like neurobio classes, you may have learned about this before, but we've got neurons, right? And so, ooh, that's ugly. That's okay. It's an ugly neuron. We're gonna roll with it. We're not gonna judge neurons by Dr. Myers's ability to draw them. Alrighty, there we go. That looks much better. Okay, so you've got two neurons, and within a neuron, messages are conveyed electrically, right? Using ions down the axon, the big part here. But what happens when you get to wanting to communicate with another neuron is you don't want to send electric signals just across synapses in the brain. This part in between is called the synapse. Because you would give yourself seizures all the time. Not a good idea. We don't want to do that. So instead, what we do is this neuron that's sending the message is going to release neurotransmitters. So again, in this case, it's going to be some norepinephrine. And then those will go across to the next neuron and fit in to these little receptors, things that they attach to. When they attach, that tells this next neuron to send the electric signal down its axon. And so it's come from this one. And what you'll notice is that, okay, all these receptors are filled, but there's still, right, some norepinephrine just kind of floating around. Well, typically what happens is the sending neuron, the body doesn't like to waste things, right? So it kind of acts like a vacuum, and it sucks those leftover norepinephrines or whichever neurotransmitter we have back. Well, what can happen in people with depression and anxiety is that that vacuum is overactive. So it might even suck some of these back up before they can attach and send the signal. So what these medications do is they basically go in and block some of the vacuum ports. In that case, the norepinephrine is going to bounce around in the synapse more, and these ones are going to go over and give it more power to send the message. And so the tricyclics do this with norepinephrine. The SSRIs we're going to talk about in just a minute do this with serotonin. And so these medications come in, they block these receptors, these sucker-uppers, reuptakers, and then they let more go across the synapse and send the message. Now, tricyclics and some of these other medications do take a while for their effects to be known. So with the tricyclics, it can be 2 to 8 weeks for them to kick in. And that's a long time if you're really depressed, right? So sometimes people find this really difficult. Negative side effects are also really common with the tricyclics, including weight gain and just like not feeling like yourself. The other problem with tricyclics is you can overdose on them. If you take too many of them, you can die by suicide. Marshall Linehan, who is one of the brilliant therapy creators of our time, has a saying, no lethal drugs for lethal patients. So if you know someone has suicidal thoughts, you don't want to hand them something they could use, right, as a tool to end their life. And so people were like, we can do better. So the next thing they came up with was the MAOIs, or monoamine oxidase inhibitors. And so monoamine oxidase, MAO, is an enzyme that breaks down norepinephrine and serotonin. And so what can happen, similar to the reuptakers being too active, is sometimes your MAO, that enzyme, can be overactive. It's like you have too much of that enzyme. So it comes in and it breaks down your serotonin, your norepinephrine, before it can get across and send a signal down the next neuron. These are slightly more effective than tricyclics. What's really interesting with this is because MAO is also responsible for how we synthesize some foods in our digestive tract. You cannot eat certain or drink certain things. So like you can't have certain cheeses, you can't drink beer, you can't drink red wine. So for some people, that makes these just not an option. If I could not eat cheese, I would be very sad. Cheese is like my thing. You know, it's a comfort food for me. And so this would not work for me. And so the more modern ones include the selective serotonin reuptake inhibitors, or SSRIs. And so they are going to selectively block reuptake of serotonin. So again, let's say there are more reuptake little vacuum suckers on this one. They're only going to block a few of them, right? They're not going to block them all. Prozac is the most popular one, but it also includes things like, I just had and I lost it. Not Zyrtec, that's an allergy med. But there are other ones as well. You know what, I'm gonna Google it real quick because it's, brain is not braining, so. There we go. So these are some of them. Zoloft was the one I was trying to think of. Paxil is pretty well known. Lexapro, Celexa, these are some that are pretty well known. And again, these work really well. People tend to have pretty minimal side effects to them. So they're gonna take them. They also do take a while to kick in, but it's usually more like 4 weeks instead of 8. So again, that makes them better than the tricyclics. And maybe the most important, it's really hard, if not impossible, to overdose on SSRIs. So they pose no unique risk of suicide or violence, no lethal drugs for lethal people. These will be a good option there. You can get some negative side effects, but these are much more innocuous than other antidepressants. And let me see if my hyperlink still works here. This was an ad, yes. that came out
You know
for
when you feel the weight of sadness.
for Zoloft, again, one of the popular SSRIs. I want to say this came out in the early 2000s. I just find it a little amusing. It's somebody thought this was going to sell their medication. Let's just put it that way.
You know when you feel the weight of sadness. You may feel exhausted, hopeless, and anxious. Whatever you do, you feel lonely and don't enjoy the things you once loved. Things just don't feel like they used to. These are some symptoms of depression, a serious medical condition affecting over 20 million Americans. While the cause is unknown, depression may be related to an imbalance of natural chemicals between nerve cells in the brain.
What I tried to draw.
Prescription Zoloft works to correct this imbalance. You just shouldn't have to feel this way anymore. Only your doctor can diagnose depression. Zoloft is not for everyone. People taking MAOIs or Pimozide shouldn't take Zoloft. Side effects may include dry mouth, insomnia, sexual side effects, diarrhea, nausea, and sleepiness. Zoloft is not habit-forming. Talk to your doctor about Zoloft, the #1 prescribed brand of its kind. Zoloft. When you know more about what's wrong, you can help make it right.
Just like the idea that someone was like, you know what we should do? Make a bouncing ball. That'll sell it. Um, but I like that ad because it does show this process, right? Which is so interesting because they don't really explain it in the detail I did, but they get at the same idea. Oh, righty. That's okay. That was the same video. So, okay. So what about some of these other, more difficult to treat disorders? Well, for bipolar disorder, for example, you can use something called lithium. And this is a common salt that is the primary drug of choice for bipolar disorder. And it can stabilize the mood swings. It can have very severe side effects. And so one of the things you need to do if you're on lithium is have your dosage and the amount in your bloodstream very carefully monitored. So this is a lot more time going back to your psychiatrist more frequently than if, let's say you got a prescription for an SSRI and they were like, cool, come see me in 6 months, right? And the funny thing is, as long as we've been using lithium, which is a really long time, we still don't fully understand why it works. It doesn't have a mechanism like this that we can just draw out. But we know it works, so we're going to keep using it. What's really interesting for bipolar disorder as well is the anticonvulsant medication, so epilepsy medications can also be helpful. So things like Tegretol and Depakote. Now, there are risks of antidepressants for children, and that does include teens. So back in 2004, when I was starting grad school, the FDA had a lot of hearings about this because they were finding risks of suicide among these folks. And so here is sort of the explanation of what happens. When you are really super duper depressed, you can't do anything. You don't have motivation. You are just exhausted all the time. And what can happen as an antidepressant starts to kick in is you might get the motivation and the energy back, but you might not have fully dealt with all the negative thoughts and feelings. And so it's like it gave them enough energy to attempt to die by suicide, basically. And so for that reason, some antidepressants now have a black box warning on their packaging that basically says, be really cautious prescribing this to teenagers and children because of this risk. And so doctors and pharmacists know to be very cautious, double check everything. There we go. We know that there are drugs to also help treat things like the psychotic symptoms in schizophrenia. So the very first generation of antipsychotics were called neuroleptics. An example is Risperdal. And these reduce delusions and hallucinations. They sort of help the person come back to reality. But they only reduce those positive symptoms, you know, the added on symptoms, the things that normal people can't see or hear or experience. They do not treat those negative symptoms, the symptoms that are more like depression, at all. Neuroleptics also have very severe side effects, including something that's called tardive dyskinesia. And this is basically a syndrome you get when you take too many neuroleptics, where you end up having involuntary movements of the tongue, the jaw, and the extremities. So it gives you almost like a tic disorder from taking this medication. There's also what's called neuroleptic malignant syndrome, which is a rare but fatal condition characterized by muscle rigidity and elevated body temperature. So obviously we want to be super careful when using those. And luckily we have second generation or atypical antipsychotics. These treat both positive and negative symptoms. And they have way fewer side effects. But patients who take the second generation ones are still moderately to severely affected by schizophrenia. So it's sort of like, do you want something that's going to knock away your delusions and hallucinations, but there's all these side effects? Or do you want something that'll like make you feel better, but it won't take away everything? We're working a lot on therapies and other things that treat schizophrenia better. So these give an example of some of these types of drugs in a lot more detail. So again, we know that in general, some of these things works, but they don't work for every disorder. So for example, it may be less effective for something like generalized anxiety disorder, where you're just sort of always worried, right? But maybe for like agoraphobia or panic disorder, these are more helpful. And again, you're going to see moderate to honestly much better improvement with the depressive disorders. And then lithium, again, that substantial improvement, but you've got to be careful of that toxicity. And then schizophrenia, again, partial improvement, but you can have all these not so great symptoms. One of the clients, actually, the only one that I know for sure was diagnosed with schizophrenia who I treated. I didn't specialize in psychotic disorders, so I only ever treated one person with schizophrenia. She had been put on a cocktail of medications that helped with her delusions, hallucinations, paranoia, but it made her gain about 80 pounds. Which, you know, I'm not one to judge about weight, but it's not something she put on naturally. It's not something her body was supposed to have, right? And so a lot of what she and I worked on was just adjusting to her body, figuring out ways that she could start moving, and also just those negative symptoms of schizophrenia. They are really tough. They are like very severe major depressive disorder. Alrighty, so I mentioned there are some other biological treatments here. Electroconvulsive therapy has been around almost since we knew how to use electricity. It is used to treat severe depression and severe other psychopathologies like psychosis. And so what you do is you attach electrodes all over the person's brain, you're not drilling in, their skull, their head. And then an electrical current is sent through the brain, and it helps a great deal. As I mentioned, you're going to try a lot of other things first. And this does result in temporary seizures. So again, just like if electricity jumped from this neuron to neuron, it would be a seizure. Sending electricity through the brain does the same thing. In the olden days, this was horrific. People just like full on had horrific seizures. They would dislocate their shoulder while having ECT. It was almost barbaric, in my opinion. Nowadays, they'll do things like give you a muscle relaxant so that you don't thrash around. They'll do things like strap you down so you don't injure yourself. Uh, Usually they do like 6 to 10 treatments and it works. Um, we are not entirely sure, just like lithium, why this works. The best analogy I've heard is it's like turning your computer on and off when it's acting up. We're not shutting down the whole brain, but it's kind of like giving it a burst of energy. And so the side effects are actually few, but they can include memory loss. So I did see someone for a neuropsychological evaluation who'd had ECT, and she did have memory loss as a result. It's fairly rare and usually pretty mild. And in her case, it was sort of moderate. It can be more than that. There was actually, gosh, this was a while ago, maybe 14, 15 years ago. There was a Broadway musical called Next to Normal. And one of the plot points was that the mother in this family had really severe psychopathology, I think bipolar disorder, and she had ECT and she lost a lot of her memory, like dramatic amounts, right? Because it's Broadway. But really interesting to see mental health portrayed in that way in a musical, and it won a bunch of Tony Awards and whatnot. Now, neuro or psychosurgery, these again have horrific histories. One of the things that they did, especially in the early 1900s, was prefrontal lobotomies. And this is going to be a gross description, so apologies in advance. But what they would do is usually go in through like the eye socket, sort of between your eye and the skull. And they would go into the prefrontal cortex, which is right here. And this controls things like your personality, your organization, your emotions. And they would basically just mess it up. Like the original prefrontal lobotomies were done with an actual ice pick. Like back in the day before we had freezer technology, people would just get big blocks of ice, and then when they needed it, they'd chip it off. That's what they sanitized it, but that's what they use. So they would just kind of go in and like squish your brain around, basically give it a lot of injury, and people would be very passive afterwards because you've basically taken away their personality and their emotions. We don't do that anymore, but there are psychosurgeries we can do that are effective and ethical, right? Examples include deep brain stimulation. So they can install something like a pacemaker in your brain that will stimulate parts of your brain that would release things like serotonin to help with depression. And there are a couple different procedures like that. The other thing that I don't have on this slide, but that I should mention, is there are new ways of getting at the same thing electroconvulsive therapy does, including TMS, transcranial magnetic stimulation, where they basically like aim a big magnet at parts of your brain. You don't have seizures, but it does seem to do sort of the same sort of reset thing. And I don't know if they're still doing it, but for a while EVMS was doing that. Oh, and I do have a video about TMS, so that's good.
What we're actually treating is the left prefrontal cortex of the brain. We're seeing lack of blood flow to this area of the brain where we think it's impacted by depression. With this magnetic impulse that we're sending to that area, what we're seeing is increased blood flow to that area and ultimately alleviation of the depressive symptoms.
When you sit down for transcranial magnetic stimulation, the probe will be placed on your dorsolateral prefrontal cortex. It's an unusual feeling, like someone tapping on your head, but it's not painful. Some individuals are a little bit more sensitive to it than others, but in general, it's fairly well tolerated. So you're receiving good therapy, you're eating healthy, you're doing these things to help your depression get better with the support of Roger's team. At the same time, we're activating a part of your brain that has been dormant for a while, likely contributing to your depression. And when you do healthy living, psychotherapy, and you're waking up this part of your brain through the TMS, you have a better chance of feeling better and overcoming the depression. So it's important in our view to make sure that you're not just relying on transcranial magnetic stimulation to help you feel better, but you're doing some of the other things necessary to get the improvement.
The initial session that the patient will come in for is actually called the motor threshold determination, but we call it the mapping. And that is where the attending physician will come in and actually determine the treatment location on the patient. The mapping involves using single pulse stimulation over the motor cortex to stimulate the right thumb. Once we get that involuntary response in the right thumb, we know that we're in the general vicinity. The attending physician will then move around slightly millimeter by millimeter until we pinpoint the most precise location. From there, we determine.
And the reason they have to do that is because everybody's brain is wired very slightly differently, right? All our neurons continue to grow connections throughout our lives.
And how much energy is needed to actually penetrate the skull and the skin and muscle to hit that location again and get the same response.
Same thing, people just naturally have skulls of different thicknesses, right?
Move into treatment location and we perform the first treatment. The patients following treatment start with the TMS technician going over a couple of review questions. You know, how did you sleep, any pain, discomfort from previous treatments, etc. After that, we get the patient set up, make sure they're positioned correctly. Then we actually place the treatment coil on the scalp. Treatment now is only 18.5 minutes. We recommend 30 treatments, which would be considered a full course. Treatments are Monday through Friday, 5 days a week. Treatment's done, we take the patient out of treatment position and they are good to go.
And again, obviously way less invasive and problematic than something like, ECT or psychosurgery. So, alrighty, on Wednesday we will talk about Freud and how he did therapy and go into some of the other talk therapies.